Hello, everyone. Um, and then, okay, it looks like everyone's joining. Great. So, welcome. Thanks again. I know that we had a big training yesterday, so it's good to see a lot of you again. And I think we have a great presentation here today from Sarah. Just wanted to do a few housekeeping items. And then if everyone can introduce themselves in the chat if they get a chance, just so we don't have to go through and unmute. And then, yeah, so Elsa, do you have some updates that you wanted to share with the team? I know we had a few.
Sure. Hi, everyone, and welcome to our December monthly call, the last one for 2022. So great to see everyone again, and thanks everyone for spending the afternoon with us yesterday. I know that was a long session, but hope it was very helpful. We are really excited for our guest presentation today, but I also, before we launched into that, just wanted to share about a couple other things on the horizon. So the first is that the Patient Navigation Training Collaborative, which is changing their name slightly, but our partners there recently received a large grant from HRSA to develop a community health worker training program. So they're partnering with Trailhead Institute and the Colorado Alliance of Patient Navigators and Community Health Workers. So for the next 3 to 5 years, they'll be recruiting 80 people into the field of community health worker, and CHW is being used as an umbrella term to include community health workers, health navigators, promotorists, salute, and other positions. So they're having new training curriculum and opportunities related to the CHW field, and we'll be helping pay for training for people to get CHW training. And then also for those that go through the training program, there'll be the opportunity to be matched with a field placement of either a internship or an apprenticeship. So they are both looking for people who are interested in participating as trainees to become a community health worker. So this might be for newer people in your organization or those that would be considered more going out into the field versus working directly in the clinic, but it does include health navigation as well. And then they also are looking for sites that would be interested in hosting trainees who receive this over 130 hours of training from the PNTC to then get matched with a site for an unpaid internship that's at least 130 hours, or a paid apprenticeship, which would be 1 year to really develop their skills. And so with both opportunities, there's great opportunities for sites who are looking to grow use of community health workers in their organization, as well as those that are really looking to help bolster the field for new trainees. So they're in the initial stages, really getting the full program up and running, but looking to start the first cohort of trainees in the spring, probably around April, May time. So we would love to hear if there's any groups that think that would be a good fit to either host a CHW at their organization for an internship or apprenticeship. And we'll be receiving support from the PNTC and the Alliance, or if you're interested in having anyone from your organization participate in the training and internship and apprenticeship opportunities, I'll drop the link in the chat where people can just submit a sign-up form to show that they're interested. But there's a lot more to come on that, but just wanted to plug it as it's getting started. All right, I think that's everything I had from my end, Wesley, unless there's anything else about our other upcoming trainings and programming.
No, I don't think so right now. I'm just finalizing a few of those and we'll get agendas out as we know more details. And then I'll send the link that Elsa is going to send in the chat in the follow-up email as well. And like a little summary of what she said and what the asks were. But yeah, thank you all for introducing yourselves. And now I'm going to do a brief introduction of our presenter and then I'll let her take it from there. So we have Sarah Robinette joining us from UC Health, and she is an oncology nurse navigator. So she's going to walk through the process of GI nurse navigation in oncology and discuss the handoff between primary care and specialty care following a cancer diagnosis, and just give us, a history of what she does and how she does it. So, Sarah, I'll let you take it from there.
Okay, thank you, Wesley. I appreciate it. Hi, everyone. Thank you for having me today. As Wesley said, I've been asked to speak about our navigation process. And so hopefully I answer some questions and am helpful. Just a little bit about me. I've been an oncology nurse for 17 years, working in a variety of backgrounds, inpatient and both outpatient. I've worked as a team lead, a charge nurse, an inpatient oncology nurse manager, an accreditation manager. In Wyoming, I managed a women's care clinic and a vaccination clinic. Right now, I'm currently working for UC Health as a nurse navigator. My primary sites are GYN, neuro, and lower GI. Personally, a little bit about me. I am a mom of 2 little boys, 12 and 10 years of age, and a mom of a furry friend, Winston. I'm also a trail runner and a mountain biker, hiker, skier. Just love playing outside and being outdoors in Colorado. Before I start, I do just want to be transparent. I've been a navigator for only going into, I guess this is my 3rd year, and different institutions use navigation in different ways. But what I want to go over is just how we here in the North region support our patients through the navigation process. And one of the, one of the main reasons that I'm so passionate about navigation is I get to be put in a special place where I hope to create more equitable care for our patients. Disparities are still in healthcare every day, and I hope to lessen those disparities for our patients, and that is what navigation allows for me. So just a little bit of a review of our objectives today. I'm going to talk a little bit about history and navigation, understanding the role of a GI navigator, and discuss handoff to primary care. And with the history, navigation in 1989, there were hearings held in 7 cities around the US. The hearings were called the American Cancer Society hearings. And they found that underserved and poor populations faced substantial barriers to obtaining cancer care. I'm sorry, guys, I have it on slideshow. I apologize, and it's gonna keep forwarding for me. The hearings found that patients face substantial barriers to obtaining cancer care and often did not seek care if they weren't able to pay for it. The hearings also found that patients endured greater, Wesley, do you mind advancing for me? Sorry, I have it on this slideshow and I'm struggling here.
Yeah, I can.
Sorry, guys.
No worries.
And do I need to end sharing or something for you?
It looks like maybe I can take over.
Okay.
Is that working?
If you'll go back 1 slide.
Can you all see that now?
And if you'll go back 1 slide for me. And back again. think you need to go back a couple slides, sorry.
Oh, no, it's fine. Is it, which one were you on, the Herald?
History, yeah.
Is it not showing?
It is still advancing for me.
Oh, weird.
Yeah, it might be that the setting needs to be changed.
And I'm gonna end my show and see how that
Okay.
works.
Maybe it's that you have to end yours. And
Oh, wait, there's use timings, looks like a checkbox at the top toolbar.
Say that again.
Use timings is checked on the toolbar of PowerPoint. So in the middle of that toolbar. So keep going to the right where there's the check boxes.
Used timings.
Yeah. I hope that helps.
Okay, Wesley, do you want me to take back over then?
yeah, you can try it. And then I removed my screen share so we can see yours.
Okay, sorry guys. Technical difficulties here. Thanks for bearing with me. Okay. Again, the cancer hearings showed that patients in underserved and poor populations endured greater pain and suffering than most Americans who were going through cancer care. It also showed extraordinary personal sacrifice for those patients in obtaining and paying for cancer care. And then it found that education programs were culturally insensitive and irrelevant to many of the poor and underserved populations. And this led to the nation's first navigation program in Harlem, New York, created by Dr. Harold Friedman. The first navigators were volunteers and lay persons. And the program was put into place to decrease barriers to the underserved population suspected of breast cancer. The results from Dr. Freeman's patient navigation pilot were impressive and had a lot of findings. Some of the main ones were mammograms that had findings, excuse me, mammogram findings were higher. Sorry guys, let me try again. Women who had mammogram findings were more likely to get biopsies with the navigator. The navigators help the patients get to testing sooner. And that is what I work on in my role, is to make sure that patients are getting into testing, biopsying images that the provider needs sooner. So as soon as I have a diagnosis, I'm working on making sure that we have all of that workup in place. And sometimes I have to push a little bit to make sure that patients are getting what they need in a timely manner. So from the 1990s, when navigation started until now, we've seen significant changes going from a lead person to clinical staff navigation. And in doing so, we've needed to create a framework and a scope of practice and competencies for our professional role. The Oncology Nurse Society, which is a national organization, helps create those standards for oncology nurse practice and has set that framework for us as navigators. They find the core competencies as coordination of care, communication, education, and a professional role. And just to go through a little bit of all four of those. So care coordination, we help facilitate the delivery of healthcare services. I don't know if any of you have had friends or family members who have had cancer, but if you have, you know that the healthcare system can sometimes be very convoluted. Sometimes patients will see up to 20 providers during their first year of treatment. And I have seen that in practice. Communication, as a navigator, we must demonstrate interpersonal communication to enable the exchange of ideas and shared information. And education, providing appropriate and timely education to patients and families to support decision-making. And the professional role aspect is how do we work to advance our education and our professional development to best support our communities and institutions and our teams. And working within our scope that ONS has created and our organizations who we work for has create, we look at barriers to care. And barriers can be anything from financial or insurance barriers, transportation barriers, emotional or social barriers. These are things that I touch on each time I'm visiting with a patient to kind of get a grasp of is anything impeding their care that we're trying to get for them. There also can be physical barriers, pain, ambulation, any barriers due to recent surgery. So those are all things that I'm looking at when I'm assessing a patient. I had a patient today who needed a PET scan, and he's getting a PET scan tomorrow, called me, did not want to drive to Longmont. So it's about a 40-minute commute for the patient. And I kind of dug into that a little bit and found out it wasn't about the travel or the time, but it was cost. And so getting that patient set up with an oncology social worker and getting him evaluated for financial support. I was able to get him gas cards this morning. He will make it down to his PET scan. So it's pieces like that that I'm assessing when I'm meeting with patients. The next piece is education. So I'm, for one, finding out what's the best way that the patient learns. Is it demonstration? Is it reading? Are they an English speaker, a Spanish speaker? Understanding what's the best preferred method for them to receive education, and then going over resources and referrals with them. And with our referrals, we have a lot of resources, and I know Denver does as well at Anschutz, for social work, nutrition, counseling, physical therapy. These are all things that I'm looking to see how best I can support the patient. I work to educate the patients on their new diagnosis. I share appropriate resources for education on the diagnosis, and then I create referrals and review supportive services when I meet with them on that first visit. As far as facilitate shared decision-making, meaning once the patient has all the information they need from the physician and their providers, I want to help them gather the resources, have the education, and have an open, honest discussion about what are their goals of their care. And I often, on the first visit, discuss, or at least bring to the table, advanced care planning. That's an important piece that we try to hit on with each visit, and discuss advanced directive with all the patients, and stress the importance of creating that document within their EPIC chart. And then supportive and palliative care. This is an important aspect of patients' care. I'm looking at, do they have chronic pain? Are there a lot of comorbidities that they're trying to manage along with their cancer care? And to see if they're in need of extra support in palliative care. This is really why hopefully I can be helpful to you, and kind of going over what we do here in the North region. The reason that I named this slide GI Navigator role in the North region is because different organizations and different areas, even within an organization, will use navigation in different ways. So I just want to put that out there. But this is kind of the way that we manage patients here in the North area. I know that as a system, we're working on having a more standardized navigation process. So we're all doing similar things. But right now, I know Anschutz functions a little bit differently than we do here in the North region. So how I typically get involved in a new patient's case is a referral from primary care or a GI clinic. That would be after a biopsy, after a colonoscopy, imaging studies are done, and I would receive a referral. Once I get the referral, I'm going to look into the patient's chart for either that colonoscopy report, that biopsy report, pathology, imaging studies. If I don't have all that I need for a diagnosis, I'll reach out to our intake team and see if they've received those reports, or I'll call the primary care office to see if the patient has completed the workup. With that, sometimes our providers will see patients without completing the workup, but a lot of our providers prefer primary care completing that workup before they see a patient, meaning they would like a tissue diagnosis before the patient is brought in for at least our GI cancers. And then once I review the chart, I have all of the workup. When I'm able to, I'm going to reach out to that patient, introduce the role of nurse navigator, and discuss some of our supportive services with them at that time. In that first call, I want to create a positive rapport with the patient. I want them to kind of really know that I am a resource and a support for them, and let them know we understand that this is an extremely stressful event and that they have someone there to support them and to advocate for them. With the first visit, the patient comes in, it's my goal to be at that first visit. Sometimes I will have multiple patients that are in the same slot because I provide support for several different primary sites and all of our docs. So sometimes it is hard for me, and I will try to give those out to other navigators, but I'm not always able to, but it is my goal to at least call them before that first visit, if not be in that first visit. I take notes for them. And like I said, we'll go over resources that we have here at the Cancer Center. I'm addressing those barriers or needs and really getting an understanding of where they're coming from, what is their housing situation, who is in their home supporting them, do they have transportation, are they working full-time, are they retired, and really getting to know my patient in that first visit. That's really important because if they have a barrier such as transportation, we can have an amazing oncology team. They can have the best care plan in place, but if they don't have transportation to get here, we're kind of stuck. So that's something that I need to be addressing. And I go through, you can see the tool here from the NCCN. This is a tool that I use before I walk into the visit. The patient will fill this out. And this is something that they do when they come in for the first initial visit. And it addresses physical concerns, emotional concerns, social concerns, practical concerns, and spiritual. And then they use that thermometer on the left to rate their distress. This tool also is used to flag our social work team to support the patient, but this is a big guide for me looking at things that they are concerned or worried about. And I get to walk in the door just having this information can start my conversation with this tool and getting a base of where they're coming from. And it's really, really helpful. After the visit, the provider, once they wrap up, answer all of their questions, as I'm note-taking, I sit down after the provider leaves and will re-review my notes. Sometimes the patient is absolutely overwhelmed. They've been given not only a new diagnosis, but they've gone over their treatment plan and next steps, and they are just flooded. And what I try to read my patients really well. I'll say, are you ready to review this, or do you need me to send you home with this note and we can review it later? And it just depends on the patient. Sometimes they're ready to kind of dig in a little bit more with me because they feel able to ask more questions. I put the picture of the power port on here because a lot of our patients are going to start chemotherapy, and so I review that with them. I show them pictures, I show them an actual port. I'll take that into the room if I know they're getting ready to start chemotherapy and they're going to be referred to interventional radiology. I will take the device in there so they can touch it and feel it and we can talk about it. But I really walk through those next steps of a port placement, imaging studies, PET scans, CT scans. What do those involve? What do we need to do for prep? Just each thing that the provider has, ordered for us, I will kind of walk through if they're ready. And again, if they're not, then I will make that phone call, that afternoon or the following day and say, okay, are you ready to talk about next steps? Most patients I find are wanting to do it, at that first visit. And then at the end, I do discuss advanced care planning because that is an important piece of their overall care. After the visit, we'll step out. I will coordinate appointments. So again, setting up PET scans, imaging studies, biopsies when they're needed, setting them up for interventional radiology and getting their port placed, setting them up with a surgeon if they have potential surgery down the road after chemotherapy. And then I will make referrals. Again, if they need social work, if they need a nutrition referral. And I didn't talk about that when I was discussing barriers, but sometimes nutritional status is a major issue for our GI patients. And that's a referral that I often make is for our dietitians. And so entering in all of those referrals that I have found, if there are barriers or they need supportive services, I will enter those referrals. And then once I coordinate appointments, get everything lined up for the patient, once they're in treatment, what I do is I step back. They get turned over to an RN care manager, and the RN care manager manages side effects, drug refills, and helps with their care as they're going through treatment. I am still always available, and that's what I tell my patients. As they're starting, I'm really heavy on the upfront. Once they're in treatment, I kind of pull back and follow their chart. I will monitor as they're going through treatments. If they have a 3-month scan, I'll be setting a reminder for myself, looking at scans, making sure they're either stable or improving and not progressing on treatment. If they're progressing on treatment, we may change treatment regimens, and then I would come back in for that visit with a provider, do additional note taking, talk about changing treatments, and just be a support for them so they have someone there who can kind of walk through that with them. And then once they're finished with treatment, if our goal is for cure, then what I do at the end of treatment is enter a survivorship care plan. And with that, the primary care can review that with the patient in the patient's chart. So that is kind of an overview of that, receiving the referral, walking through the patient's chart, making contact, introducing our role and how we support them, and then that first visit and coordination of appointments. A little bit about colorectal cancer, because as I said before, I am the GI, lower GI navigator. I thought I would put a slide on here, just general facts about colorectal cancer. It's the third leading cause of cancer death for both men and women in the US. That's why it's imperative for early detection. And there's strong evidence that colorectal cancer screening decreases colorectal incidence and mortality. As many of you are aware, the colonoscopy screening age has decreased from 50 to the age of 45. And hopefully we can help increase this knowledge throughout our community, because I see patients every day that are over 50 who have not gotten their screenings, or of the age of 46, 45 who have not gotten screening. So it's important for us to get that information out. Despite the efficacy of screening, almost 40% of eligible adults are not screened at recommended intervals, and many have never had any type of colorectal screening. Screening failures occur not only from a lack of screening, but also from breakdowns and follow-up on tests, which negate the benefits of screening. I feel like that's where we really come into play, is making sure we're following through. Once we have a positive pathology from a colonoscopy, we're making sure we get them referred to an oncologist or a surgeon, and really getting them where they need to go in a timely manner. And as far as the handoff, the first piece is confirmation, like I talked about earlier, of a diagnosis. You don't want to have a patient coming into a medical oncology office unless they need to be there. I have seen it sometimes. Something's found on a scan, they're referred to us, our oncologist, or, wanting to support the primary care, and so they will get them in, but then they don't have a oncology diagnosis or a cancer diagnosis, so they didn't need to be seen. So just making sure that we confirm a diagnosis before they're seen in our clinics. Once this is obtained, the referral should be placed for oncology plus or minus radiation, and that would be dependent on their diagnosis. Reaching out to the navigator, we can help review charts and answer questions. And then the primary care would need to communicate that the referral has been entered and that the oncology team would be reaching out for that appointment. As far as primary care, they're still going to be managing their diabetes, their overall health. What oncology is taking over is just that oncological piece, but they're still going to see their primary care provider for any other issues that they're having health-wise that they were seeing prior. And as far as the survivorship care plan, like I said, this is something that the primary care can review with the patient in the patient's chart. So if they have Epic access, they can walk through that and let the patient know how often, once they're finished with treatment, they're going to have scans, they're going to have imaging, they're going to have labs to surveillance their cancer. And knowing where to go. This is such an overwhelming event for many patients, and knowing what is next is so helpful and imperative for the patients, just to have a sense of I won't say peace, but somewhat calm, and having a navigator support them in that process has really been helpful. Just letting them know, okay, these are the next steps has really, I hear it every day from patients, how thankful they are, how grateful they are, just knowing that they have a support and an advocate here for them, and that they know what's next. It's really been amazing, and that's part of why I love my job so much. We are a community resource, so you don't need to have cancer to speak with one of us. We are here to help. And if if you don't have a diagnosis, hopefully we can help you get to where you need to be and point you in the right directions. The few things that I have here are resources. These are some of the resources that I use to give guidance to my patients to make sure that they're using reputable sites when they're looking at either pancreatic cancer or colorectal cancer. The NCCN guideline is kind of my go-to as navigators. This is kind of a document or a space that we live in. Once we have a diagnosis, this will help guide us in knowing what imaging studies, what labs we need. And so we can help kind of preempt conversations with the provider and saying, are these the things you're looking for? Can we enter those for you? Can we get the patient set up for these before you come in? So we really live in this, the National Cancer Guidelines. And then the last slide I have are my references, and I am open to questions. Thank you all for your patience with my technical difficulties there in the beginning. And I will take any questions if you have any. I hope that was helpful.
Thank you, Sarah. Yeah, so if anyone has any questions, feel free to come off mute and ask them. We have about 23 minutes left, so plenty of time to do some Q&A. I have a question. Is it that all patients who are referred to your practice interact with you or an oncology nurse navigator? Is that something that everyone gets?
Yeah, so we have 7 nurse navigators. We have 2 breast navigators. There are 2 GI navigators, head and neck, lung, heme. So yes, that is our goal as the navigation program here, is to be a support and provide navigation for all new diagnosed patients in our cancer center.
Great, thank you.
Yeah.
Sarah, this is Elsa. I have another question for you. What are some of those common barriers that you would say that you're helping patients overcome or find solutions to after a new diagnosis? And is there anything that primary care navigators or teams can do to help alleviate some of patients' concerns of there's those warm handoffs from primary care to oncology?
I love that question. Thank you. I think one of the main barriers is emotional support. So getting in touch with the navigation team and saying, hey, Mrs. Smith was just diagnosed with colorectal cancer. She is completely overwhelmed, doesn't have a lot of family support. What can you do to help her emotionally? And just reaching out to us and letting us know this is going to be someone that we really need to do a lot more hand-holding and maybe get them set up with counseling right away, or just to be that extra ear for them to feel like they have a little more support. Or financial issues, that is a big one. Knowing to get social work involved early. So I have a lot of patients that come in without insurance or the best coverage, I'll say, and knowing to reach out to navigation to say, this is a patient coming in without, insurance, or, has just lost their job and has lost insurance. How can we support them? And we have a lot of charity care that we're able to help patients that don't have insurance coverage. I had 2 this week that needed PET scans, biopsies, and they had no insurance. So knowing upfront if I can connect them for charity care is really helpful, because the sooner I can get that approved, the sooner we can get them in for the testing and workup they need to get done.
This is Laura with Valleywide. I have a question specifically with regards to those individuals who don't have an insurance.
Mhm.
What about like the undocumented? Are you able to provide these services to them?
We are, yes.
Perfect.
And
Thank you.
I could not tell you what that program is called. That would be our social work team. But yes, I've had, over the last 1.5 years, I've had more than a handful of patients come in that are undocumented and able to get them care. And again, different, I know Anschutz is different than here in the North region, but I know we all have access to be able to support those patients.
Thank you.
Yes, thank you. And the sooner we know that piece, like I said, the better for the patient, that we can get that paperwork started and get them the care that they need.
Awesome. Any other questions for Sarah? It doesn't sound like it. So yeah, thank you so much. This was super helpful to understand what your process looks like on your side and what sort of support and work that you do with the cancer patients. I think that this has been really insightful. So really appreciate your time.
Yeah, and like I said, Wesley, we are here as a community support and happy to help. So please feel free to reach out to us, and we can give guidance. What I do see with primary care is a few of the providers in the community who know me, if they have a GI cancer coming in, will reach out and say, hey, what do I need to finish this workup for oncology? And so, like I said, I will be using national guidelines to say, well, this is what guidelines say. And I know that that's what my provider, the oncologist, is going to recommend. And so they'll finish the workup by reaching out and just touching base with us. It's helpful, and we're there to support the primary care. So please reach out to us.
And I'll send out a follow-up email. Do you mind if I include your email and these slides?
Oh, not at all. Yeah, I hope this was helpful. Like I said, I was very general, but hopefully that answered a few questions.
Yeah, and I'm sure if folks have other questions that they think of later on, they'll have your contact information or can always relay through us. But yeah, this was super, super interesting. So thank you. Elsa, I don't know if you have anything else to follow up on towards the end. And if not, we can give people 15 minutes back of maybe their lunchtime.
Yeah, thank you so much, Sarah. We really appreciate it. And also folks, if they need any assistance connecting with Sarah or have any specific questions, we can also relay them, but we'll get the slides, the recording, and Sarah's contact information sent out, as well as the follow-up with all the resources from yesterday's training. So a lot coming everyone's way, and we'll have more information for our upcoming trainings going out shortly. I think Wesley's already sent out some of those calendar invites. And lastly, I'll just mention that we are getting towards the midway point of our fiscal year. So we'll be reviewing how many screening allocations every clinic has used and kind of checking in and seeing how things are going after the new year. But if we don't talk to everyone again before the holidays, wishing you all a very happy holidays and happy new year.
Thank you, Elsa.
Thank you, guys.
Thanks, everyone.